The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device. Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insights in hemorrhagic stroke care. I'm your host, Sue Abelt, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
Introduce Navi Sangha.
Thanks, Dr. Koenig. I just wanted to take a minute to say thank you to the Hawaii Stroke Coalition for giving us the opportunity to bring you some great volunteer physician speakers today. We're excited to have them both, and I will turn it over to my colleague, Sue Abelt, to introduce Dr. Sangha.
Good morning, everyone. It is my privilege to introduce our first speaker today, Dr. Navi Sangha. Dr. Sangha received his neurology training at Kaiser Permanente, LA Medical Center, and completed his vascular neurology fellowship at the University of Texas, Houston. He is currently the Regional Medical Director for Stroke and Telestroke in Kaiser Permanente, Southern California, and an Associate Professor at the Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Sangha's interests include improving systems of care to help implement processes that improve clinical outcomes at both primary and comprehensive centers, as well as enrolling patients into emergent stroke trials at the primary stroke centers via telemedicine in order to decrease disparity of care in clinical trial enrollment. Dr. Sangha, the floor is yours.
Thank you, Susan. Thank you, everyone. Nice to meet you, and I really appreciate the opportunity of being able to present today. I'm going to take myself off video so I can just, begin presenting. And so today we're going to be speaking about acute blood pressure management in intracerebral hemorrhage. I have no disclosures. So we're going to be reviewing intracerebral hemorrhage demographics, the etiologies of intracerebral hemorrhage, and really going to focus on the data on acute blood pressure management in intracerebral hemorrhage, and then after that, strategies to attain the guideline-based blood pressure recommendations. So if you look at our population health metrics, we know that intracerebral hemorrhage is actually has a lower incidence and prevalence than ischemic stroke. So about 700,000 strokes a year in the US are ischemic strokes, where about 80,000 are intracerebral hemorrhage, and a smaller percentage, about 16,000 are subarachnoid hemorrhages. There's definitely a difference on how ischemic stroke and intracerebral hemorrhage pan out in terms of both morbidity and mortality. We know that in early term, intracerebral hemorrhage mortality is about 30 to 40%, much higher than ischemic stroke. And at about 6 months, only about 20% of patients with intracerebral hemorrhage are functionally independent. The incidence of intracerebral hemorrhage by race and ethnicity has been well studied. It's about 1.6-fold greater among Black and Mexican American individuals compared to white and non-Hispanic white peoples. And it's 2-fold greater among Asian populations compared to non-Hispanic populations. We also know that intracerebral hemorrhage incidence is higher in low-income and middle-income countries, as well as actually low-income compared to middle-income areas within higher-income countries themselves. But moving toward etiologies of intracerebral hemorrhage, the majority of intracerebral hemorrhage, about 85% of it, is either related to chronic hypertension or cerebral amyloid angiopathy. So we can do a lot for prevention for intracerebral hemorrhage if patients have their blood pressure well controlled, can probably prevent about half of intracerebral hemorrhage out there. Cerebral amyloid angiopathy, of course, is a disease which we don't necessarily have the best grasp on at the moment in order to have a preventive strategy, but a lot of studies are happening with CAA of the vessels. Of course, there's CAA of, there's cerebral amyloid drugs that we have for Alzheimer's disease. They don't necessarily translate to those for amyloid angiopathy, however. The next thing that causes intracerebral hemorrhage commonly is anticoagulation intracerebral hemorrhage. Albeit it's less than it used to be in the days where most patients received warfarin. With the direct oral anticoagulants, the risk of intracerebral hemorrhage on anticoagulation is lower. However, it is probably the third still highest cause of intracerebral hemorrhage. Then there's other things which are less common, like vascular malformations, such as AVMs or AV dural fistulas or cavernous malformations, cerebral venous sinus thrombosis, more esoteric things like reversible cerebral vasoconstriction syndrome, of course, hemorrhagic transformation of an ischemic stroke, a central nervous system infection like herpes can cause temporal hemorrhage, mycotic intracranial aneurysms, moyamoya disease, cerebral vasculitis, cerebral hyperperfusion syndrome, post-carotid endarterectomy or carotid revascularization, sickle cell disease, and other just bleeding disorders or diastases. And then what is the actual mechanism of brain injury when someone has an intracerebral hemorrhage? There's a direct pressure effect, which results in local compression and injury due to increased cerebral pressure. And there's also cellular pathways that get involved, resulting in inflammation and toxicity of the actual blood products. Both potentially are worsened by hematoma expansion. And that's really kind of the holy grail of intracerebral hemorrhage, to prevent worsening and to improve both morbidity and mortality, is to decrease the hematoma expansion when someone has an intracerebral hemorrhage. So what causes a hematoma expansion? What are the most common things associated with it? It's associated with, well, we know hematoma expansion is associated with neurological deterioration and worse outcomes. In patients with ICH, every 1 ml of hematoma expansion leads to a 5% increase in the odds or death or dependence. We also know that hemorrhages tend to expand in the first few hours after presentation, and in most patients, the hematoma expansion occurs in the first 3 hours after symptom onset. And that's really going to be important to understand as we talk about some of the clinical trials, which looked at blood pressure control for intracerebral hemorrhage and their subgroup analyses, as well as other clinical trials that are being done right currently on intracerebral hemorrhage, where the target actually is the immediate treatment of the disease, if it's medical management, within its early onset in order to reduce that hematoma expansion. In the past, oftentimes we were using time periods such as 4.5 to 6 hours from the ictus when someone had intracerebral hemorrhage, but we've learned that that might be just too late to introduce medical therapeutics. And if they do need to be given, they probably need to be introduced immediately or really early on in the disease process. Predictors of hematoma expansion include shorter time from symptom onset to initial imaging, which makes sense. If you get into the hospital quickly and you have a head CT which shows a small hemorrhage, we know that the likelihood of expansion might be greater only because you're presenting earlier. If you present later, you've probably already expanded. A larger baseline hematoma, anticoagulant use, of course, contrast extravasation such as the spot sign, and some non-contrast CT markers of hematoma expansion, such as the blend sign, black hole sign, and the island sign, and of course the acute hypertensive response, which we're going to focus on in subsequent slides. Here are some examples of these CT markers. So here's contrast extravasation, or the spot sign. This is on a CT angiogram. You can also see it with a post-contrast head CT. Just shows a little spot within the hematoma where contrast is extravasating from a vessel that's burst and caused the hematoma to form. This is the blend sign where you see different ages of the hematoma. So the more hypodense area is probably earlier hemorrhage, and that is the area that might be a greater risk of expanding. And here's the black hole sign. Similarly, also can increase the risk, predict the risk of hematoma expansion. and the island sign, which is small little islands of hematoma surrounding the larger hematoma. They may coalesce to expand to form one large hematoma, and also a sign of possible imminent hematoma expansion. So if we talk about the acute hypertensive response in ICH, that's what we're going to kind of focus on today, on how to really manage patients and how to quickly get our patients treated. But hypertension is commonly seen in patients who acutely present with an interstitial hemorrhage, and it's associated with hematoma expansion and worse outcomes. There are two large randomized control trials that have assessed the effect of intensive blood pressure control on clinical outcomes. One with INTERACT-2, the intensive blood pressure reduction in acute interstitial hemorrhage trial, and ATAC-2, the antihypertensive treatment of acute cerebral hemorrhage. We are going to talk about a newly published trial as well, which we can add to the data, but these were the two initial pivotal trials, which really kind of helped to inform the guidelines as they've been written today. And so these two studies showed that with INTERACT-2, lowering systolic blood pressure to less than 140 millimeters per mercury within 6 hours of onset showed a non-statistically significant marginal improvement in outcomes. ATAC-2 found no difference in outcomes between intensive blood pressure control, and when you were saying that it's SBP less than 140 versus standard blood pressure control of SBP 140 to 179. Now, the important thing is both of these studies, they actually try to enroll patients up to 6 hours of onset, right? So that might be part of the issue why they didn't show an improvement in outcome in these patients. But when we look at subgroup analyses of the acute hypertensive response with ATAC-2, they found that the early blood pressure control within 2 hours of ICH onset was associated with a lower risk of hematoma expansion and an improved 90-day outcomes compared with those whose blood pressure was controlled greater than 2 hours. There was also evidence of a lower risk of hematoma expansion actually with these patients as well. Here are the grotto bars on the left showing the improvement in outcomes. So the top section is the section which shows if the patient got treated within 2 hours, and the bottom section is if it was greater than 2 hours, and there's clearly a difference in outcomes. Similarly, if they got treated within 2 hours, there was a statistical improvement in hematoma expansion, functional independence, good outcome, but still no difference in death. Which is very common for most stroke trials, even ischemic stroke trials. Oftentimes we don't find a difference in mortality, but our goal is usually to improve morbidity overall. Similarly, INTERACT-2 showed that systolic blood pressure reductions of greater than 20 millimeters of mercury within 1 hour of randomization, and in whom systolic blood pressure was maintained for a week, were associated with a lower risk of disability and death. And so this also kind of goes to the fact that we want to not just reduce the blood pressure, but maintain the reduction. But early on reduction of the blood pressure probably is better than later on for these acute stroke patients who present. We also found in another study, the intensive ambulance delivered blood pressure reduction in hyperacute stroke, which is actually just published May of this year. This was the INTERACT-4 study. It was done in China, and it was a really interesting study where patients were treated with acute blood pressure reduction when they had acute symptoms by the ambulance at their homes, right outside their homes, before we even knew if the patient had an ischemic stroke or an interstitial hemorrhage. And what they found was when they looked at the global outcome of both ischemic stroke and interstitial hemorrhage, combined them, there was no difference in outcomes. But when they separated out the patients for ischemic stroke and interstitial hemorrhage, there was a clear difference. The ischemic stroke patients actually did worse with acute blood pressure reduction in the pre-hospital setting. And those patients with interstitial hemorrhage actually did better. They had a decrease in the odds of a poor functional outcome if they had rapid blood pressure reduction. The odds ratio was 0.75 with a confidence interval of 0.6 to 0.92. And here are the grotto bars below showing the modified Rankin scale of 0 to 3 actually improving in patients who had the blood pressure reduction if they had an interstitial hemorrhage compared to those of usual care. I think it's pretty intuitive for the ischemic stroke patients. We often tend to let the blood pressure ride, and we don't want to reduce the blood pressure very quickly. And there's been other studies which have shown that also. but this actually is probably the first study to show that intracerebral hemorrhage patients benefit from acute rapid blood pressure reduction and not just in a subgroup analysis. ESOC in this past European Stroke Organization conference also had a meta-analysis presented by Dr. Jia Wang of individual patient-level meta-analysis of the 4 INTERACT studies. The main result was treatment of patients within 3 hours of symptom onset with blood pressure, tight blood pressure control, improve the outcomes of patients. So it's really that early treatment which really helps to improve outcomes overall. We also found that through subgroup analyses of INTERACT-2 and combine it with ATAC-2, that blood pressure fluctuations may worsen outcomes. So it's important that we don't just chase our patients with boluses of labetalol or hydralazine, but really consider starting them on an intravenous drip like nicardipine or clofidipine. Maybe consider labetalol drip, but maybe a calcium channel blocker if it's suitable to the patient, depending upon their comorbidities. And so in this pre-planned analysis of INTERACT-2 and ATAC-2, they show that patients who achieved lower systolic blood pressure with less variability, specifically during the first 24 hours after intracerebral hemorrhage, that it was safe, first of all, but also that it improved outcomes. So probably important to avoid those large fluctuations in systolic blood pressure. And then finally, a secondary analysis of INTERACT-2 showed that patients treated with intensive blood pressure control that had a mean systolic blood pressure of less than 130 had an increase in disability, but those with systolic blood pressure between 130 to 139 had the best outcomes. So maybe don't want to reduce it too much, right? So that kind of gives us our lower threshold of how low should we decrease the blood pressure in patients when they present acutely. And that's really what the guidelines based their guideline statements on. So the 22 intracerebral hemorrhage guidelines based their statements on everything I just kind of reviewed, except of course INTERACT-4, which was not yet published. It was just published this past year. So what the guidelines state are that medication titration to ensure continuous, smooth, and sustained control of blood pressure, avoiding peaks and large variability in systolic blood pressure can be beneficial at class 2A level of evidence, a pretty high level of evidence. Initiating treatment within 2 hours of ICH onset and reaching the target within 1 hour can be beneficial to reduce the risk of hematoma expansion. Once again, maybe that 3-hour target window, right? Because we know that most patients probably have expanded by 3 hours. So really kind of getting those patients in early, of course, and treating them quickly. And if ICH of mild to moderate severity, presenting with a systolic blood pressure of 150 to 220, acute lowering of the systolic blood pressure to a target of 140. So that's kind of a median of 140, with the goal of maintaining in the range of 130 to 150 is safe and maybe reasonable. And we might be thinking like it's really hard to keep that range of 130 to 150. And I can show you, I'm going to show you some data with what we did at Kaiser Permanente in Southern California, that actually it's quite feasible to do so as long as your hospital system is willing to provide the nursing staff to help maintain that blood pressure in that tight range. Because what we learned is from the previous slides is that if the ICH is mild to moderate severity and we reduce the blood pressure below 130 systolic, it's potentially harmful. So we want to try to keep it in that sweet spot. And that can be difficult and does require intensive care for the patient, whether it be started in the emergency department and then continued in the ICU or a specialized unit that's dedicated to intracerebral hemorrhage or stroke care. So in the AHA in 2024, just this past year, early winter, put out this performance and quality measures for spontaneous intracerebral hemorrhage. And one of the quality measures that they really wanted to have was a time to blood pressure target, quality measure number 4. And what they had said was that the writing group hoped that adding that BP target as a quality measure based on a class 2A recommendation would encourage clinicians to be thoughtful about the importance of setting blood pressure targets and reaching it, therefore allowing for collection with potential for later transformation into a performance measure. So really important that we're starting to think about blood pressure control acutely in intracerebral hemorrhage. I think as stroke neurologists, maybe as ED physicians and ICU physicians, we are often focused on acute ischemic stroke care, but I think it's time to open up our minds and really think about this other stepchild of stroke, which is intracerebral hemorrhage, to see how we can really improve outcomes. And so with this, the AHA proposed has some proposals for blood pressure target related blood pressure related time target measures, which may even be related to an AHA future award. So the time to administration of blood pressure lowering agent is going to be one of them. So I'm sorry about this table and how it showed up. We're going to be looking at the percentage of patients with intracerebral hemorrhage and whom acute blood pressure lowering is considered, who have a blood pressure lowering agent administered within 60 minutes of arrival. So that means a patient hits the ED, they're a candidate for acute blood pressure lowering, at least those patients who present within 2 hours of their last known well time, and we start a blood pressure lowering agent within 60 minutes of them hitting the door. And then the goal is how quickly will we get the blood pressure under control once that blood pressure agent is started. And so the AHA has proposed that another target will be the percentage of patients with acute spontaneous intracerebral hemorrhage in whom acute blood pressure lowering is initiated and in whom the target blood pressure is reached within 120 minutes of hospital arrival. So you get your blood pressure medication started within 60 minutes and hopefully controlled within another 60 minutes, so a total of 120 minutes or 2 hours from hitting the door. And so how are we going to get this done, right? How are we going to change our systems or maybe understand our local hospital or ED metrics to get to these outcomes? So there's a special report published in the Journal of Stroke earlier this year as well. And what they called out was for ischemic stroke, we have all these little sections and areas where we have well-defined components on how to treat patients. We have well-defined imaging. We know that certain patients need CT and CT perfusion for EVT candidates. There's inconsistent utilization of that intracerebral hemorrhage. There's uncertainty in what to do. We have well-defined blood pressure parameters for patients who receive thrombolytic therapy. For for blood pressure, it's well-defined now by the guidelines, but it's still class 2B level of evidence, and there's no agent that's really recommended specifically. We also know there's hematologic therapy, of course. For example, there's thrombolytics for acute ischemic stroke within 4.5 hours. And there's really no standards for emergency reversal of anticoagulation. However, the AHA is working on that and will be coming out with something. And regarding surgical intervention, similarly, we know that EVT works really well for ischemic stroke patients, but the role of craniotomy is unclear. So when we're looking at ICH to its analogous partners for acute ischemic stroke, there's still a lot of research to be done and things to move in order to ensure that our patients will have good outcomes. But what we're going to focus on is the blood pressure control today. And so one of the ways that we can kind of alert our teams is to consider having a code ICH, whether that's something that's a overhead code in your EDs or maybe your hospital systems. That can be a local decision, or it can just be a process. Of course, it's different than a code stroke, right? A code stroke might turn into a code ICH, and a patient may never even have a code stroke, and that can still turn into a code ICH. Because interestingly, about 20% of ICH patients may present with vague symptoms, headache, nausea, vomiting, and not really necessarily the usual BFAST symptoms, which initiate a code stroke at many of our centers. So once the CT scan shows a hemorrhage, perhaps initiate a code ICH, whether it's an internal ED code, just a process code, or maybe a hospital-wide code. And if the patient's on anticoagulation, reverse the anticoagulation quickly. And of course, if the patient's blood pressure is greater than 150 millimeters systolic, you really want to reduce the blood pressure quickly as well. And then repeat a scan between 6 to 24 hours to show stability. And so we thought here at Kaiser Permanente, Southern California, that in order to reach these blood pressure targets, it might be important to mimic something that's been really successful. The guideline recommended acute blood pressure control in ICH. So we know that phase 3 target stroke has these great time metrics laid out, that how quickly should a physician see a patient, how quickly should the stroke team see a patient, how quickly should a CT scan be done, and then interpret it, and then how quickly should we be giving thrombolytics, as quick as 30 minutes. It used to be 60, then 45, and now we're all trying to get this 30-minute goal. But it's these door to metrics which has allowed to move the care for ischemic stroke. And so we thought it was important to consider creating door to metrics for blood pressure control as well. And this is what we envisioned within our system for blood pressure control for intracerebral hemorrhage. Door to blood pressure medication ordered. This is for patients who present with code strokes, I should say. So once you have a code stroke or a brain alert, a code brain algorithm, and you see that intracerebral hemorrhage on CT scan, we should be measuring door to blood pressure medication ordered, first blood pressure medication ordered to medication given. That's really important because you might order the medication, perhaps your nursing staff and team does not have a code ICH process, and then the medication is being given 10 to 15 minutes later. Or maybe your medication is not in the CT scanner or in the PICSs where it can be given immediately, and you have to go back to the ED to give it. That's why that's important to measure. The door to blood pressure medication given, of course, so then what happens from the door to when the medication is given, and then first blood pressure medication ordered to systolic blood pressure in range, and finally door to goal systolic blood pressure in range. Now, if a patient doesn't present with a code stroke and they're kind of going through a non-code stroke algorithm, maybe for those patients who have these vague symptoms, it's going to be the same things, except we're replacing the door to time to CT interpretation time. And so the AHA has also given us some strategies to get our blood pressure really quickly controlled for patients. So of course, they recommend initiating the treatment within 2 hours of ICH, and reaching the target within 1 hour can be beneficial to reduce hematoma expansion. They recommend using standardized protocols and order sets to reduce disability and mortality, and also recommend having nursing staff with specialized stroke competency education that can be effective in improving outcomes and mortality. So we use some of these recommendations to kind of create our protocols, work with our nursing staffs and our ED physicians to get that blood pressure down quickly. They also found that it was important to have a bundled ICH approach, a bundled approach to ICH care. So we know from Interact 3 in a publication in Annals of Neurology that with a study called the ABC ICH study, that care bundling really helped with time targets for anticoagulation reversal and blood pressure control and immediate access to neurosurgical and critical care services. And they found their reduction of blood pressure needle to target times from 43 minutes versus 333 minutes when it wasn't bundled, and significant reductions in mortality, actually. And Interact 3 was a randomized control trial done in China and actually some of the Southeast Asian countries as well as South Asia. And they found a bundled approach of intensive blood pressure lowering, correction of hyperglycemia, and reversal of anticoagulation really helped to reduce poor functional outcome. The modified Rankin scale at 6 months was lower in the care bundle group, a common odds ratio of 0.86 with a confidence rate interval of 0.76 to 0.97. Interesting, however, blood pressure control was the most common intervention in this bundle. Most frequent patients didn't often have hypoglycemic responses, and not many patients were on anticoagulation, which merited reversal. And so even though it's important to consider this bundle, the blood pressure aspect is probably the most important component to the care of these patients. So in our system, we decided to create an ED ICH order set, which actually was pre-checked. So it's really easy that any one of our ED physicians or anyone from the stroke team can open the order set and just click sign. They don't have to think about clicking other things. And what it included was all the necessary orders to take care of your intracerebral hemorrhage patient in the emergency department without really having to think what was needed. So we have our blood pressure control for our patients, right? So labetalol, because labetalol might be available immediately in your PICSs or in the ED. And then in our system, we use Clevaprex, not clevidipine. We're not endorsing it here. That's just what we've chosen in our system. As well as it also had the aspect of clicking if a patient is on an oral anticoagulant right in that same order set with the appropriate reversal agent. If they're on warfarin, to start the patient on a human prothrombin complex concentrate, Similarly, if they're on a DOAC, to give the appropriate reversal agent as well, all in one order set. But in addition to that, we also put some really important nursing components as well, measuring the vital signs, the neurochecks every hour, keeping that head of bed elevated, checking the glucose, of course, because that's important from Interact 3, right? We learned that. Maybe implementing seizure precautions, not necessarily giving the patient AEDs, but just perhaps ensuring that the patient is being watched for seizures because of the increased risk. And then we also added a PT, an INR, and a PTT because this patient may not have gone through a code stroke algorithm where the patient needs to be assessed with a PT, an INR, and PTT, and they may have presented with vague symptoms that got a head CT, and so important to get those checked as well. If they've gone through a code stroke algorithm, they very well would have likely have had these orders, but some of our patients who have ICHs may not go through those algorithms, and so important to kind of add those as well. And of course, continuous cardiac monitoring, all of this pre-checked. So just open and sign. But if you do want to add additional things like reversal agents or mannitol, we did put other components into the order set to allow our ED teams, whether it's the stroke team or the ED physician team, to quickly have a one-stop shop for our ICH patients. And then based on that order set and the recommendations from the guidelines and all the previous studies that we talked about today, we decided to initiate an emergency department process improvement for daughter blood pressure control via implementation of the ICH-related time metrics that we talked about, combined with nursing staff engagement, education, and feedback. And so I really want to give a lot of credit out to my colleague, Yvette Straight. She's our assistant clinical director and educator in our emergency department at Kaiser Permanente in Los Angeles. And then our vascular neurology fellow, Ashkan Javidzadeh, who kind of helped to put all the data together and will hopefully get presented and published pretty soon. And so what we focused on were four main things: nurse knowledge, blood pressure management via the guidelines and establishing blood pressure time metrics in our ED, medication accessibility to make sure that our ED had the right medications in the right places to start the blood pressure reduction immediately. And then, of course, to ensure your nurse-patient ratio was ideal for that initial titration of blood pressure if they were started on a drip to get that blood pressure to this right goal. And so we started off with implementation of nurse knowledge. Our nurses in the ED, we actually have what we call stroke champions, both daytime and nighttime in the emergency department. And they basically had a small flyer and they informed the nurses that the goal blood pressure control is actually 1 hour of arrival. So we had a much more stringent goal than what the AHA is recommending, which is 120 minutes from the door. We wanted to actually control the blood pressure within 60 minutes of arrival. And we also made sure that they all were aware that the goal of the blood pressure is a systolic blood pressure between 130 to 150. So we recommended that to give 2 doses of labetalol because labetalol was readily available at the bedside for these patients, and then titrate using clofidipine every 90 seconds until the blood pressure goal could be achieved for our patients. We also introduced a Pyxis in our CT scanners, and we put labetalol in that Pyxis in the CT scanner. So while the patient is in CT, if the head CT shows an intracerebral hemorrhage and the order set got shot off, they can actually just grab the labetalol and give it to the patient while they're in CT or while they're en route from the CT scanner back to the emergency department. So they've already begun the blood pressure control immediately when the intracerebral hemorrhage is seen. And or sometimes we might want to get additional scans for our patients of intracerebral hemorrhage. Maybe we're interested in getting a CT angiogram. So what they do in that case is that they do get the labetalol, and while the CT scan team, while the CT radiology technologist team is setting up the contrast for the scan, they'll give the labetalol, and then they'll run the CT angiogram, and then they'll take the patient back and or get ready to give a second dose of labetalol if necessary, and then take the patient back to the emergency department to start them on that IV drip. And of course, like I said, we use this order set, which has everything pre-checked in it, specifically the labetalol and the clofidipine, that says to use 2 doses. If you can't get the blood pressure down, then start that clofidipine drip. I have to be honest, based on our study that we did internally at our one center, we're probably going to just move to one dose of labetalol and starting clofidipine right away, and maybe a little bit of a higher dose of labetalol. But we wanted to start off with being a little bit safe and not dropping the blood pressure too much, so it didn't go to that less than 130 goal. So we're probably going to change that. This is our current order set, however. And then, like I said, it's important to have implementation of accessibility of your medications. Before, clofidipine was being stocked in our pharmacies because it is a refrigerated medication, but we started to stock it in the refrigerator in the emergency department with other refrigerated medications, really allowed for quicker access. And you can do something similarly in your emergency departments, whether it's nicardipine or clofidipine. Nicardipine doesn't require refrigeration, actually. And then we also informed our nursing teams that the expectation, once the patient is on clofidipine, that they need to have their blood pressure titrated every 90 seconds until the systolic blood pressure goal was reached and maintained. And that's actually what the package insert says for clofidipine as well. But in order to do that, you can imagine you need one-to-one nursing. So we were able to meet with our partners for the hospital and talk to them about the importance of having one-to-one ratios for our intracerebral hemorrhage patients up front. So once the blood pressure was controlled, then the ratio can then be extended back out for that patient. But we wanted to ensure that the patient's blood pressure was controlled, at least having 2 blood pressure readings of less than 150 systolic. And so during that time, to be 1-to-1. And then the nurses, other patients would automatically get distributed to their neighboring nurses, and they would get them back after, if appropriate. If the patient required continuous one-to-one nursing, we would allow them to have stay with that patient. But oftentimes, most patients didn't need that once the blood pressure was titrated, and once we kind of reached that sweet spot of 130 to 150, then the titration didn't need to continue every 90 seconds, and then could be extended to Q1 hour after that. And so we looked at our pre-intervention time period for these patients. So we kind of studied if it was effective in reducing our door to blood pressure goal time metrics. And so our pre-intervention period was January 1st, 2021 to December 31st, 2022. And our post-intervention period was January 1st, 2023 to May 31st, 2024. And like I said, what we did was we broke down these 5 components of blood pressure control in the ED: door to blood pressure medication ordered, first blood pressure medication ordered to medication given, door to blood pressure medication given, then first blood pressure medication order to the systolic blood pressure in range of 130 to 150, and of course the overall door to goal systolic blood pressure of 130 to 150. And what we found was that, yeah, we actually did improve time intervals, our time metrics. So our door to blood pressure medication ordered decreased from 19 minutes to 13 minutes. Our first blood pressure medication ordered in systolic blood pressure range to 130 to 150 decreased from 75 minutes to 43 minutes. And our CT interpretation to first systolic blood pressure in range of 130 to 150 decreased from 97 minutes to 49.4 minutes. And the big goal, ED door time to first systolic blood pressure in range of 130 to 150 decreased from 98 minutes to 60 minutes. And these were all statistically significant. So in conclusion, what we found was that it's really important to understand your local ICH time metrics, education, both ED physician, stroke neurology education, your residents, your fellows, and our ED nursing colleagues really improves implementation of really anything, I would say, but specifically for blood pressure reduction and intracerebral hemorrhage. Medication accessibility expedites intervention, and having those one-to-one nursing ratios really allows for timely blood pressure management. And I think we can all get this blood pressure reduction goal of systolic between 130 to 150 really quickly, similarly to how we're able to get our door to needle times down from 60, 45, and now 30 minutes. I think we can get these door to blood pressure goals down to 60 minutes as well for at least half of our patients if we try to implement some strategies in our emergency departments. And that's it really. I wasn't sure if I'm able to open it up to questions now, or should I, is that after the second speaker?
I know we can try for questions now. I don't know, Nicole or Dr. Koenig, you can probably handle the room on your end, but we have time, and I think the technology will work for us to do that.
Great. Can you hear me, Navi?
Yes, I can.
Okay, perfect. We're going to take some questions from the audience. It's a small group here, so I think you'll have to come to the mic to ask your questions. So I'll get a line of people here to ask questions for you. And while people are lining up, I'm going to ask you about your thoughts about the ENRICH clinical trial. And for the audience, that is the first quote unquote positive clinical trial of minimally invasive surgical evacuation of hematomas. And I'm just interested within Kaiser Southern California, how you're interpreting those results and how that may have changed your surgical management of intracerebral hemorrhage.
That is a really good question. So we're actually in talks currently with our neurosurgical partners on how we can implement it. As you know, ENRICH was presented, I think, about a year and a half ago, but just only recently published about 4 months ago. And so we were waiting for the publication to come out to kind of better understand the specific populations. And of course, the basal ganglionic hemorrhages, they were removed from the study. Well, they stopped enrolling them in the study because they didn't really have a lot of benefit. And it was really those cortical hemorrhages. And ENRICH used a very specific device. So I think it's where, similar to thrombectomy, right? Where when in the older days when I was a resident, and maybe some of the rest of the individuals in this meeting were residents, where you were using that Mercy stent retriever, that corkscrew, which is really painful, right? So with thrombectomy, the device is caught up to the disease with the stent retrievers. And I think this device is actually a different type of device where it allows both suction and visualization at the same time, decreasing the number of devices that need to actually go through the cerebral cortex in order to allow for hematoma expansion. And so I think it's important, if we're going to mimic the study, we probably have to use the device that was used in the study, because previous studies that looked at similar cortical hemorrhages didn't really pan out, right? And so I think that's what's going to be important. We're trying to figure that out. A lot of our neurosurgeons are actually pretty excited about it, especially the younger ones who are recently graduated from fellowship. And so we're going to be starting a working group on that and how we can incorporate it within Southern California.
Thank you, Navi, for the presentation. Great information. My name is Tristan. I'm one of the ER managers on one of the outer islands. And what we're seeing is when these patients come in, typically they're in extremis and their airway is compromised, large intracerebral bleed. And what we're typically doing is we're managing that airway first. And in so doing, we're doing RSI, we're getting sedated, and we're finding that we're having a difficult time with blood pressure management immediately afterwards. And I was just wondering if you had pearls for the staff that could avoid those pitfalls where we have the blood pressure dropping, because initially they come in hypertensive and then they drop after RSI and sedation, and then it starts creeping back up. And so we're wondering when that sweet spot is on getting that blood pressure management initiated, because we're ready to start these new protocols to get that blood pressure in that range quickly.
That's a really good question. So I do want to give a little bit of background. So we studied patients who were mild to moderate hemorrhages, specifically because the severe hemorrhages, the ones that end up probably getting intubated, they tend to have poor outcomes overall. And so there's a lot of uncertainty and the utility of immediate blood pressure control for them. Nonetheless, we actually recently looked at our data on how our protocol may have spilled over into all hemorrhages, right? Whether they're more severe hemorrhages and have end up being intubated. And what we found is that you're totally right. So the patient gets intubated. We don't really know if they've had a hemorrhage usually up front, right? It's just a clinical suspicion because they're coming in and they have a low GCS, and you're going to intubate them even before the head CT. And once the head CT is done, we still activate the order set, and we still put the nurse 1-to-1. And when the blood pressure, and then we cycle the blood pressure every Q5 minutes for these patients, because we want to start to ensure that we catch that the rebound in the blood pressure again. And oftentimes it's starting to rebound really about 45 minutes to an hour is what we found after the intubation itself. And so that tends to be, looks like the sweet spot. And so the nurses are aware that they need to just be vigilant and have the clofidipine ready. For these patients, we actually just skip straight to the clofidipine because it's a little bit more of a controlled environment in that they got intubated, they're back in the ED, they were a little bit hypotensive maybe up front, and so we're just kind of waiting to catch that blood pressure going back up. And so instead of going through our usual route of labetalol times 2, then clofidipine, we just start the drip for them.
Hey, Dr. Sangha. I'm Danae from the Comprehensive Stroke Center here. So for those mild to moderate ICH, we see them titrating the clofidipine every 90 seconds. And sometimes what I'm seeing is, it drops under that 130 and maybe even under 100 systolic. So any, helpful tips on what to do with that? Because I'm trying to think through should we be waiting 2 minutes or something, to catch that, or what should we be doing?
Yeah, I mean, I'll be honest with you, every 90 seconds is probably a little bit difficult to do still, and in reality, it's probably every 2 to 3 minutes, right? Because with every 90 seconds, you're just kind of repeating blood pressure, getting that blood pressure cuff going every time it turns off, probably starting it back up again, because it takes about 90 seconds, 60 to 90 seconds for the blood pressure cuff to give an interpretation. Now, what's nice about clofidipine, and I don't mean to endorse it, but this is the reason that we chose it, is because both for ischemic stroke and for interstitial hemorrhage, that is a very short half-life, which is not dependent on liver or kidney function. It's esterase metabolized. So in about 2 minutes after maybe, what we do is if they overshoot, we just tell them to cut it in half, actually. And so then it usually rebounds back very quickly, just in minutes. So you're not less than 130 for a very long time. And so that's our protocol. It's just to cut it in half. And then re-begin the titration if necessary. It's not often that we're having overshoot down here, and so it's usually. This is a median, so we've only been able to achieve this quick blood pressure control in about 50% of our patients, right? And so it'd be nice that we're able to achieve it even in more patients. But I think that's the benefit of clofidipine, that if you shut it off completely, which I don't recommend doing that, I usually recommend just halving it. And it'll bounce back very quickly since the half-life is only about 2 minutes. Does that help to answer the question? Sorry.
That answer your question?
Oh, yes.
Okay. Hi, Dr. Sangha. My name's Cassie. I'm the stroke coordinator at Maui. And I've just got a really simple question. Who actually does the wet read for that CT scan that you guys do at imaging in order for that emergency room RN to give that first dose of labetalol in the CT scanner?
Yeah, it's a really good question. So I'm going to answer it in 2 different ways, because in Maui is a primary stroke center or an acute. What level of stroke center are you guys in Maui? Sorry.
Yes, we're primary.
Primary, great. So I'll answer it from the comprehensive level and then the primary level, because I think it's important, right? So at the comprehensive level, we're lucky we have residents and fellows. And so the resident will acutely interpret it with the attending in the background or virtually, or the fellow will interpret it. So that's kind of great that we have this large team, but that's not necessarily the reality of actually most hospitals out there, since most of our hospitals are not TSCs or CSCs. Most of them are primary stroke centers. So at our primary stroke centers, we do have a telemedicine group. Within Kaiser Southern California, all Southern California Permanente physicians that are vascular neurologists. And so for every patient that presents as an acute stroke, we interpret it. So if they come in as a code stroke, we'll interpret the head CT, and we'll actually initiate the ED-ICH order set remotely ourselves. Now, I do want to say that the data I showed you guys here today, this is purely our comprehensive stroke center data. We are looking to move this out into our primary stroke center realm right now, but it is our team that interprets it for acute strokes. If the patient presents in a delayed fashion beyond 6 hours or with vague symptoms, and a code stroke or a code 24 hasn't been called for that patient at our primary stroke center, then it's the CT scan is interpreted by a radiologist or a teleradiologist. However, our ED teams, our ED physicians have all been educated on the ED-ICH order set, that once they receive that emergent interpretation, to really activate that ED-ICH order set right away. And I think that's really helped them because it's kind of zero thinking. They know that, okay, everything's here. I can just activate it. Let our nursing teams know that please go ahead and reduce that blood pressure per the orders.
All right, Navi, this is Matt Koenig, and thanks so much for taking the time on a Saturday to join us. And we'll have to figure out how to get you out here in person next time, because there's a lot of your colleagues here. We're hoping to meet with you in person. I see Ronnie Salem here on the Zoom. I'm sure you want to say hi. And Cordia Wan here and Todd DeVere in the room. So thanks again for taking the time.
Yeah, thank you guys for allowing me to present today, and you all have a good rest of your day.
Later, Navi.
Bye.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.